We have the first presentation today. It's Dr. Rakauskas, urologist, Lausanne University Hospital. We'll talk about focal therapy for prostate cancer care in 2022. So, please.
Okay, great. So thank you for this kind introduction. It's really a great pleasure to present in such a Lithuanian yet international conference. I will start with the overview of my presentation. Speak a bit about the rationale of focal therapy, as I think it's one of the most important parts. I'll discuss the types of energy used for focal therapy. We'll take a look at the latest evidence, the ideal scenario for focal therapy, and I will conclude with the future of focal therapy. Now, I would like to begin with these two large randomized controlled trials that were both published in New England Journal of Medicine. The first one on the left is the radical prostatectomy versus observation for localized prostate cancer, also known as PIVOT trial, and the more recent one, the PROTECT trial that randomized patients to monitoring, surgery, or radiotherapy. And both of these trials, they send quite a similar message that at 10 years, we really don't have that much impact on cancer-specific and overall survival, at least at 10 years. Now, if we go back to the pre-PSA era, we have the SPG4 trial that compared randomized patients to radical prostatectomy versus watchful waiting. And as you can see in this figure, it's the cumulative incidence for prostate cancer-specific death. The black curve is for radical prostatectomy, and the gray curve is for watchful waiting. So if you take a closer look, you'll see that the men who are under the curve for radical prostatectomy are going to be those that will die despite the treatment. The patients who are above the curve for watchful waiting will be the men who could avoid treatment. And it's actually these men who are in between, these are actually the men who are really benefit from radical treatment. So again, we don't have as much impact as we would like to in treating patients who have localized disease. Now, not only we don't have that much impact on cancer-specific and overall survival, our treatment, they do come with a price. As you can see from these patient-reported outcome measures from the PROMISE trial, patients who undergo radical treatment have significantly worse results in terms of urinary continence and erectile function. Another study that I would like to discuss is the PROMISE study. So this is the study that validated prostate MRI for localizing prostate cancer. They included almost 600 men that had either clinical or biological suspicion of prostate cancer, and each patient had a pre-biopsy prostate MRI, a systematic biopsy, and a template mapping biopsy. Now, the template mapping biopsy was done with 5 millimeter precision, and the whole prostate was biopsied with a precision of 5 millimeters. Now, while this study did validate prostate MRI, I think another very interesting finding from this study is the distribution of grade group of the patients. So, as you can see here, it's 1/3 of the patients had no cancer detected, about 1/3 had grade group 1 disease, about 1/3 had grade group 2 and 3, and only a small portion of patients had high-risk disease. Now, I think it's quite representative of what we actually see in our everyday clinics. And after precise risk stratification with EAU risk tables, for example, most of the patients will have intermediate risk prostate cancer. Now, while the patients with low-grade, low-volume cancers will undergo active surveillance, and the patients with high-grade disease will undergo multimodal treatment, it's the intermediate risk cancers where we should really do our best to preserve as much function for the patients as we can. So prostate cancer is the last solid cancer in which treatment is directed towards the organ and not towards the cancer. In brain, lung, breast, kidney, pancreas, liver, and colorectal cancer, we always try to spare the organ and treat the tumor, and not remove the whole organ itself, even though most of these cancers are also quite often multifocal. And there are historical reasons why prostate cancer is the last solid cancer that we treat with such a radical approach. First reason is that it's very often multifocal. 60 to 80% of prostate cancers are multifocal. Second reason is that we did not have accurate diagnostic tools previously. Systematic trust biopsy was not a very good diagnostic tool. And finally, we did not have technology required to perform focal therapy. Now, I will address each of these historical reasons in the following slides. So, concerning the multifocality, our understanding of prostate cancer did change, and we now know that in most cases we do have this so-called index lesion, and this index lesion that drives the natural history of the disease. And it's the index lesion that has the potential to progress, to create metastases, and eventually kill our patient. Now, we also understand that low-grade, low-volume secondary lesions do not harbor these kinds of characteristics, and they can be left untreated without compromising our patients' oncological outcomes. The inaccurate diagnosis we did overcome with trials like PROMISE that validated prostate MRI, and now we can locate the lesion within the prostate, and we can clearly see where exactly is, in which part of prostate exactly is our lesion. And studies like PRECISION and many others that followed that showed us that targeted biopsies also let us precisely diagnose the tumor with the tumor. We also know that with targeted biopsies, we discover more significant disease and less clinically not significant disease. So these were the tools that helped us to overcome the inaccurate diagnosis. And finally, the technology is here. This is a systematic review that just was published in European Urology a few months ago. It's a systematic review on focal therapy in localized prostate cancer, and it included studies that were done over the past 5 years. And as you can see, over 70 studies were included, almost 6,000 patients, and with 8 energy types. So focal therapy is becoming more popular subject to study, and we do have the technology, and there's more technology on the way. Now, talking about types of energy used for focal therapy, we have thermal ablation. We can divide them to thermal ablation and non-thermal ablation. The most common and most known thermal ablation types are high-intensity focused ultrasound, otherwise known as HIFU, and cryotherapy. And for non-thermal ablation, the most known examples are photodynamic therapy, brachytherapy, and irreversible electroporation. Now, there's many more types of energy that are used for focal therapy, but these are the ones that have the most evidence. So the biggest criticism for focal therapy comes from the lack of evidence. And this is the only randomized controlled trial comparing focal therapy to a standard of care that we have available today. This trial, focal dynamic therapy, was compared to active surveillance in men with low-risk prostate cancer. And as you can see, the men who had photodynamic therapy had less risk to undergo radical treatment than patients on active surveillance. But again, this group of patients with low-risk prostate cancer is not really the group that interests us, as from the start they have quite good prognosis. Now, however, this trial did show us that focal therapy has good toxicity profile. Example, function, the grade 3 complications were even comparable to active surveillance. So the treatment can be delivered safely. And to my knowledge, there are at least 4 large RCTs ongoing right now, one in Norway, one in France, and 2 in UK. But we still need to have patience for the long-term oncological results from these RCTs that compare focal therapy to standard of care. And while it takes many years for the RCTs to give us the results on oncological outcomes, the toxicity profile of treatment can be established quite quickly. These are the results from the PART trial that randomized radical prostatectomy to focal HIFU. And you can see clearly from the patient-reported outcomes that at 12 months, 1 year after the treatment, patients who benefited from focal HIFU had way better outcomes in terms of erections and urinary continence. These are not yet published results, but these are results from the Norwegian trial that also compared focal HIFU to radical prostatectomy. And again, in their trial at 1 year, focal therapy had a much better profile in terms of urinary continence and as well erections. The results were significantly different. Now, while we're waiting for the results from the RCTs, we already do have quite a lot of good evidence that focal therapy is an effective treatment. This is a study that we published in European Urology just a few weeks ago, and it is by far the largest study reporting on focal therapy outcomes. The study included almost 1,400 men treated by focused high-intensity ultrasound. And why the study is important? It's because 90% of the cohort had intermediate to high-risk cancer. The failure-free survival was described as absence of whole gland treatment, absence of metastasis or ADT treatment, and prostate cancer-specific survival. And at 7-year, prostate cancer-specific survival was almost 70%. No patient developed metastases, and no patient died from prostate cancer. If you take a closer look to the survival curves, you'll see that patients with the low-risk disease had significantly better outcomes than the intermediate and high-risk prostate cancer. However, there was no difference between intermediate and high-risk cancer. Another study I would like to show is the propensity score match study, also published just last year, that compared radical prostatectomy to focal HIFU and cryotherapy. Now, in this trial, patients, almost 500, more than 500 patients were matched according to age and baseline clinical parameters concerning prostate cancer. And in this study, we can also see that the failure-free survival from the treatment was not different between HIFU on cryo and radical prostatectomy, 3, 5, and 8 years. And there are many other good examples, but again, we'll need to be more patient until we have the results from randomized control trials. So what is the ideal scenario for focal therapy? Simply put, it's ideal patient that has ideal treatment. So let's first define ideal patient. Ideal patient will have an MRI visible and unilateral lesion of the prostate, and that there should be a concordance between the lesion and your biopsy. Now, especially if you're just starting focal therapy, I really suggest doing template mapping biopsies, or so-called Barzell biopsies, where you biopsy transperineally each zone of the prostate. This way, you can do also targeted biopsies within the region of interest, and you can also exclude clinically significant disease that is not MRI visible in contralateral side of the prostate. Way you will avoid treatment failure. How much should you treat is a good question, and it still varies a lot from one center to another. I think this paper gives us a very good idea that was published in Journal of Urology. They included almost 450 men that had MRI visible lesions, and in the final pathology prostatectomy, they saw that MRI underestimates the actual size of the lesion visible in MRI by about 8 millimeters. So I really suggest having at least 1 centimeter of margin when treating the patients with focal therapy approach. You should also be very aware that the more prostate tissue you will treat, the more complications you will have, and the less well your patients will perform concerning urinary function and erectile function. So you should always aim to preserve at least one neurovascular bundle, and you should always try to cover your treatment needs to make sense from oncological point of view. Again, this is not cancer-sparing surgery. This is approach to really treat the cancer with preserving as much function as we can. And these are the most common templates used in focal therapy. Another important thing that you have to understand is that not each energy type is suitable for every part of the prostate. For example, lesions of the peripheral zone will be are ideal for HIFU treatment, while the anterior part of the prostate is best for transperineal focal therapy techniques like cryotherapy. Also, both of these treatments would have quite a lot of toxicity in the apical parts of the prostate, and brachytherapy is probably the way to go in this area of the prostate. So to illustrate this, there is this example from early days of focal therapy. Here you can see in the T2 sequence of the MRI a large prostate with an anterior lesion that is also visible in the ADC sequence. And in this gentleman, a focal HIFU was attempted with the EDAP machine. And as you can see, what happened after the treatment is this is the post-treatment MRI, and as you can see, the ablation zone is in the posterior part of the gland, because all the energy accumulated in the posterior part of the gland while the tumor remained completely intact. Again, this patient could have been treated with focal cryotherapy. It's a transperineal technique that could easily access this type of lesion, and you can do it with MRI image fusion, and you have real time control over the ice ball that will cover your lesion and eventually treat the patient. This is an example of focal HIFU treatment. Again, this is a lesion in the posterior part of the prostate, quite a large lesion in the peripheral zone of the prostate. And this is an MRI after the HIFU ablation. You can see a large zone where there is no contrast enhancement. And you can also see that the rectal wall is completely preserved. Now, in the peripheral zone, you can treat the prostate tissue very, very precisely. On the other hand, with cryotherapy, you would really have a hard time treating this type of lesion, because again, you would have to create an ice ball here and you would easily damage the rectal wall. So again, this is an example that for each zone to really tailor your treatment. So to conclude about it's ideally it's a patient who need not be focal therapy is not a substitute for and is not a treatment. It's needed between the patient in excess of a centimeter has to have functional from your treatment. It has to make it, and also the patient has to accept the paradox of focal therapy, and that we still need more evidence to completely validate this treatment. I would like to also say a few words about salvage focal therapy. So this is a systematic review that was published also just last year, reporting on focal therapy outcomes for radio-recurrent prostate cancer. And this paper concludes that focal therapy for radio-recurrent prostate cancer does provide acceptable oncological control and have low rates of complications. We all know that radical surgery after focal therapy has a really, really bad toxicity profile, especially concerning urinary continence. And in this paper, the pad-free continence was 87%. So it's a quite good result. Another important thing is that the grade 3 toxicity in this trial was up to 10%. So you also need that focal therapy salvage setting has a worse toxicity profile than in primary treatment, and you should really inform your patient about it prior to the treatment. And you probably should have at least some experience in focal therapy before attempting salvage cases. I would like to also finish with a case example. This is a 74-year-old gentleman that is in very good health, had initial PSA of 38 and initial Gleason score of 3+3. He had ERBT treatment in 2004 with 3 years of ADT treatment. And after discontinuing the ADT, his PSA was 5.2. Now, his PSA was stable for many years, and in 2019 and 2020 started rising until it reached 11 in April 20. And we did a PET PCMA scan at this moment, and we saw that there was a right peripheral zone lesion in the prostate with no other metastatic lesions. We did a prostate MRI, and as you can see in the contrast enhanced sequence, that there was an uptake of contrast in the same spot as in the PET PSMA scan. We did a template biopsy or Barzell biopsy, and the biopsies were also concordant with the PET CT and the MP MRI. We had 3 biopsies positive in the region of interest for Gleason 3+4 disease, with all other biopsies negative. Now, since it was peripheral zone tumor, we decided that the best treatment option will be focal HIFU. However, his whole pelvis was so fixated after the radiotherapy treatment that the probe was already very hard to insert, almost didn't move, the prostate as well didn't move. So we had to abandon the treatment while the patient was on the operating table. So we discussed with patient other strategies, and finally we decided to give cryotherapy a chance. And this is the MP-MRI 10 days after cryotherapy, and you can see a large defect in the peripheral zone of the prostate. There's no contrast uptake here. The radiologists were not that convinced because there was still diffusion restriction in the ADC sequence. But again, this is MRI 10 days after, so inflammation can occur. And here you can see the MRI 6 months after, where there's still a large zone ablated in CE sequence. And in the ADC sequence, the previous seen inflammation was not visible anymore. What about the PSA? So his PSA results were very good. At 3 months and 6 months, it was 0.03. And at 12 months, it was 0.1. The patient was completely continent after the treatment, had no complications, and he was not sexually active already previously to the treatment. So I would like to just conclude with the future of focal therapy. It has, I think it has very promising midterm results, while we still need to wait from the results from the RCTs. I think what helps the most, I think, not only for focal therapy, but for localized prostate cancer in general, is the new mammograms, radionomics, and novel biomarkers that will help us to better risk stratify our patients and to really have this personalized medicine approach where we can tailor our treatment for each patient. And I think focal therapy will have more and more important role in salvage setting. So thank you for your attention, and I'll try to answer any questions if you have.
Thank you very much for such a informative and an interesting presentation. We have one question from the audience. What MRI sequence did you use for patient selection, and why the MRI estimated could be with such inaccuracy of 0.8 centimeter?
So for focal therapy, basically it depends on where the lesion is. I mean, we use the dominant sequence according to PIRADS. So for example, if for anterior zone lesions, we'll use T2, and for the peripheral zones, we'll use ADC sequence. Now, why there is 8 millimeter, why the lesions are bigger by 8 millimeters, I really don't know why MRI is not as precise as pathology result. But again, this it's imaging. Of course, it's not going to be as precise as pathology. So I don't have an for MRI is not as precise as we want to.
So thank you very much. With this, one more thing, with this focal therapy, in your center work more urologists, or you interventional radiologists, maybe just urologists?
Only urologist.
Only urologist.
Interventional radiologist, they do perform focal therapy for, well, for kidney tumors, but not for.
So thank you.
It's only urologist.
Thank you very much.